Yeah, also thank you to the organizers for the invitation. So I'm the last speaker, and I have the role to present you a clinical researcher's viewpoint, how we can use these models which have been developed by neuroscientists in the clinical routine. And in order to do that, I will refer to data which we have worked on and also published in the past 10 years, especially in the domain of stroke. So, and we have especially focused on motor stroke because this is the most debilitating symptom which patients may have, and it's also very easy and very good to investigate in terms of behavioral parameters. So this is a study which we published about 10 years ago, where we tested how activity changes in the cortex during simple movements. So this is what we observe when healthy controls move their right hand, which leads typically to a lateralized activation pattern with a maximum activity in the left sensorimotor cortex. When the same task is performed by patients who suffered a right hand deficit because of a left hemispheric stroke, you see that the activity pattern is significantly altered, not only in the lesioned hemisphere, here the left hemisphere, but you also see additional activity in the unaffected right hemisphere. And the question now arises, what is this meaning in terms of function, in terms of reorganization? And in order to get a better insight into the meaning of this activity, we used models of connectivity, here dynamic causal modeling, to infer effective connectivity in terms of how areas work with each other and how activity in one area influences activity in other areas. So we extracted time course information from both signals in both healthy controls and stroke patients, and then estimated effective connectivity during movements of the right hand or their affected hand. And what you observe is that movements of the right hand in healthy subjects lead to an increase of effective connectivity in the contralateral left hemisphere, here indicated by green arrows, while at the same time you also observe inhibitory effects, especially targeting the motor cortex ipsilateral to the moving hand, so the right hemisphere. When we do the same analysis in stroke patients with right-hand deficits, we see that for most connections, we do not see a significant difference. With one important exception, we see an additional negative influence coming from the motor cortex of the healthy hemisphere, targeting the motor cortex of the lesioned hemisphere, and the amount of inhibition is significantly correlated with the deficit, meaning the more negative this influence was, the more impaired the patient. So based from this connectivity data, it seems that the healthy hemisphere, at least in these subacute patients, does not have a supportive role, but much rather impair motor activity in the lesioned hemisphere. However, we know that all these changes are quite dynamic in the stroke domain. And that's why we also performed a number of longitudinal experiments where we tracked the changes over time, from the very acute phase to the chronic phase. And what comes out, and also it has been found for other domains like language or attention, that this overactivity increases quite fast in the beginning after stroke, but then when the patient recovers, return to a normal level of activity. Here indicated in the motor system for a lateralized system, the better the patient recovers. And alongside with this, we also see that connectivity changes. And the best predictions for motor outcome in this group was an increase of connectivity in the ipsilesional hemisphere, so the lesioned hemisphere, with an increase of activity or connectivity from premotor areas to the motor cortex of the lesioned hemisphere, while those patients who develop over time a negative influence from the healthy hemisphere to the lesioned hemisphere are those patients who make less successful recovery. And this fits perfectly into the model of interhemispheric competition, which is a quite established model and has been discussed already for many decades now, which assumes that under healthy conditions, the hemisphere, at least at rest, are in some balance in terms of interhemispheric inhibition, and that a lesion can significantly disturb this inhibition. And this has stimulated quite a number of experiments which try then to interfere with imbalanced inhibition. For example, using non-invasive brain stimulation to increase excitability of the lesioned hemisphere in order to rebalance the system, or you can use inhibitory protocols to suppress the activity of the healthy hemisphere and thereby to improve the interhemispheric balance. And one tool which you can use for that to achieve this is repetitive magnetic stimulation. For example, in a low frequency protocol, which usually decreases excitability. And we have used this in combination with both imaging in order to see what happens if you apply this in stroke patients. So we again scanned patients and then applied repetitive TMS at 1 Hertz, either over the contralesionals of the healthy motor cortex or the vertex, the control condition. And what we can observe is that when we downregulate excitability of the healthy motor cortex, we do not only see that activity is significantly reduced in the stimulated area, but we also observe that activity in the other hemisphere is focusing, now resembling more what we would call a physiological activation pattern. And these changes in activity are associated with a significant improvement of the finger tapping performance of the patients after suppressing motor cortex activity, which is indicated here in red, compared to the control stimulation in yellow or compared to the baseline measurements. So from this study, we can conclude that we can use this technique actually to modulate activity in the brain, which then improves behavior. In the follow-up study, we then looked at how these changes impact on effective connectivity between the motor cortices. So we again use dynamic causal modeling to see, and this is just focused here on the primary motor cortex, how this intervention affects interhemispheric connectivity when patients move, again, the affected hand. And this was a baseline situation where we see this abnormal inhibitory effect, which is not present in healthy controls, and this inhibitory effect did not change after the control stimulation. However, when we downregulate motor cortex of the healthy hemisphere, we see that this abnormal inhibition cannot be detected anymore. And the amount by which we removed or reduced the inhibitory effect was significantly correlated with behavioral improvement. So that at least these data seem to suggest that the mechanistic model behind the action of TMS is indeed to reduce pathological inhibition in order to rebalance or to normalize interhemispheric effects. Of course, we can also use other strategies to interfere with cortical activity, and the other strategy is to increase activity of the lesioned hemisphere. And we now recently applied this to a group of acute stroke patients, so in the very early, so in the first few days after stroke, because our studies have shown that especially the early phase after stroke is characterized by a loss of activity in the lesioned hemisphere. And so the hypothesis was, okay, if we then try to induce activity in the lesioned hemisphere, maybe we can fasten up the normalization of activity in this area and thereby to improve motor outcome. This has also been not only activity but also connectivity is lost in the first days. So this was our primary hypothesis, and not only one stimulation but multiple stimulation. As we have seen in healthy controls, that when we stimulate multiple times, then the effects on both excitability but also neural effect on connectivity add up. So this means that we get more effective in achieving a response. So we then designed an experiment where we stimulated acute stroke patients with intermittent theta burst stimulation, which is an RTMS protocol which can increase activity in the stimulated area, and then paired this with physical training and applied this protocol over 5 days. And before and after intervention, we assessed some data in terms of behavior but also imaging. And as this has been performed in acute stroke patients, we need a control group because, as you all know, there is spontaneous recovery, and all these patients also received training. So there's expected to be improvement over time also if you do nothing, or at least no TMS intervention. And this is shown here in this figure. So left side is a control group, right side is the M1 stimulation group, and blue is the pre-interventional grip force. and red is the post-interventional grip force, and you can see that also the control stimulated group has improved, which is to be expected. However, the effects in the patients additionally receiving ITBS were significantly larger, and these effects even translated into the chronic phase indicated by the gray bars. And these changes at the behavioral level were associated also with changes at connectivity. Here we see that patients receiving wheel stimulation showed a significantly higher resting state and one connectivity with motor cortex areas of the lesion as well as of the contralesional hemisphere. So it seems that this technique has somewhat interfered with connectivity such that it increased and stabilized activity. And maybe this early increase of connectivity, which is typical, reduced in stroke, especially over time, is maybe one mechanistic explanation for the effects we can observe with this technique. Finally, we have also used prediction models with stroke fMRI data. I just briefly want to show here you two examples, for example, where we also tried to predict the motor impairment based on resting state, one connectivity using a linear support vector machine, a leave one out cross-validation approach, and by acute stroke patients, and we could show that this kind of data has sufficient information to make predictions with quite high accuracy. Even more interesting, if you want to make predictions on outcome, we can also use these approaches based on acute fMRI data. In this case, it was acute task data, where we could show that if you use these data with an SVM, you could make a high prediction in terms of motor outcome, especially in those patients where other outcome predictors like behavior failed, which is typically the case in moderately affected patients, where here fMRI clearly had a significant better outcome, especially when a signal was high in the ipsilesional motor cortex. So I would like to summarize that I hope that I could convince you that the models which have been developed by neuroscientists can indeed be implemented into clinical work and allow a better understanding of stroke deficits and functional recovery. They are also help to explain how interventions work at the neural level, and they may also be used in the future to individualize prediction of outcome and thereby also influence treatment strategies. My last slide is devoted to some caveats and problems which I think is inherent to the data, especially if you investigate patients, and here I especially focused on stroke research. One problem which we frequently encounter is the noisy or altered fMRI signal. There are many reasons for that, why we have this in patient population and especially in stroke patients. So not only that we do not have much time to assess a high number of volumes, because patients, especially in the acute phase, cannot be put into the scanner for several hours or for not even for an hour because they are severely impaired. We struggle a lot with movement artifacts, not only head movements, which are easy to detect even post-hoc, but sometimes patients start to talk during scanning, sometimes they start to scratch, and these are all effects which are, of course, contaminating the data quality and are then difficult to remove. Then, especially in stroke, we have vascular abnormalities, because basically most patients have large vessel diseases or small vessel disease, and these have a significant impact on both signal. And we have to deal with this problem if we want to apply this also in a diagnostic routine. And also medication can induce a lot of variability and can change the signal. The second problem, which I think is even more problematic, is the generalization of data, how well we can generalize the data. We usually observe small sample sizes in stroke studies, like 20 or 30 patients, and because this is why it's difficult to recruit acute stroke patients. And they have quite heterogeneous lesions. But even more problematic and not so much considered in studies is they usually have a number of co-symptoms, because patients are usually selected based on one criteria, for example, motor weakness or maybe aphasia. But patients usually have multiple symptoms like motor weakness and aphasia, motor symptoms and neglect, or even motor symptoms, aphasia and neglect. And this is often not really well modeled in these data because you do not look at it. And And we also have differences in stroke onsets. And there's also a poor definition of what is acute stroke, what is subacute stroke. Clinicians would say, okay, acute stroke is maybe only the first hours after stroke, when you can maybe rescue tissue. And maybe other people say, okay, acute stroke is the first week. And if you then just put everything together and publish that as acute stroke or subacute stroke, it's really difficult to generalize from these data. And finally, and I think it's the most important problem, how representative are our samples which we use in studies. Usually, if you look to a study, you have first-ever strokes, patients with moderate deficits who are still able to provide informed consent, for example, and have no contraindications to MRI. This is, from my personal experience, only maybe true for about 10% of the patients which we see. Patients have extremely changed even in the past 10 or 15 years. They're getting older, they have many comorbidities, and patients, for example, which I showed here with these kind of lesions are usually not included into studies because they're in coma, they're not even able to give informed consent, and we do not have any idea of how reorganization takes place in these patients, although these patients were those ones who would have the strongest need for good rehabilitation. So I think there are still some issues which we have to solve in the future, maybe with larger samples. And but I think at least we are in a good way to implement these also in the clinical routine. Maybe we have to add other techniques like EEG or combinations with TMS EEG to further inform us in terms of how the brain reacts to lesion and how our treatment affects cortical reorganization. Thank you for your attention.